Hi everyone, thank you for joining today. We'll get started very shortly. Just before we do, so I'll be handing over to the EUROGEN project manager to give an introduction to today's webinar. We'll be then playing a recording of the presentation, and then we'll take questions at the end live. So if you do have any questions, even while the video is playing, you can type them into the questions field and send them through to me. I will then pass them on to the presenters as we go. But yeah, so don't worry about doing it necessarily early on. We'll have time at the end. Should have plenty of time for questions. So thank you. So without further ado, I will hand over to Michelle Batty, the EUROGEN project manager, to introduce today's webinar. Thank you.
Good evening, everybody, and welcome to the EUROGEN webinar programme. My name is Michelle Batty, and I'm the manager of the European Reference Network, which is known as EUROGEN. So before we start, I just wanted to take the time to give a few brief words about what the EUROGEN Reference Network is and what we do. EUROGEN is one of the 24 European reference networks created by the European Commission in 2017. And we're now a network of 43 healthcare providers with highly specialised units. And what we aim to do is to deliver quicker specialist evaluation and more equitable access to highly specialised healthcare and surgical treatment for patients with rare urogenital diseases and complex conditions who need highly specialised surgery, areas where the expertise is rare, really. And some of our activities are, well, we provide virtual consultations. Our experts can provide advice given over a virtual IT secure platform, which has been provided and funded by the European Commission. We also participate in training and education activities together. For example, we have a mobility exchange programme to send healthcare professionals to different healthcare providers in our network. And we are also developing a EUROGEN patient registry covering all the disease areas within the scope of our network. So without further ado, the topic of today's webinar is stone management. And today's presenters are Kay Thomas and Matthew Bultitude, and they're both consultant urological surgeons at Guy's and St Thomas's Hospital in London. And they have a subspecialist interest in kidney stones. Kay is Deputy Medical Director and Chief of Surgery at Guy's and St Thomas's, and she's a panel member on the EAU Guidelines Urolithiasis Committee. Sadly, due to Brexit, we lost a few of our UK healthcare providers as they could no longer be members of the reference network. But we're really honoured and delighted that some, like Kay, have decided to carry on collaborating with the reference network in their capacity as an individual expert. So thanks for that. And Matthew is Clinical Director for Transplant, Renal and Urology at Guy's and St Thomas's, and he was previous Associate Editor for the British Journal Urology International and Secretary of the Urology Section of the Royal Society of Medicine. So Kay and Matt, thank you both so much for sharing your expertise with us today on stone management. And very shortly, I hope we'll be starting the video. And also, of course, please feel free, if you have a patient with a rare or complex urogenital disease, our advice is free, so please don't hesitate to get in touch. I hope you enjoy this evening's webinar. Thank you.
So thank you and welcome to this webinar on the modern medical and surgical management of cystinuria, delivered on behalf of the eUROGEN European Reference Network. My name's Kay Thomas and I'm joined by my colleague Matthew Bultitude, and we're consultant urological surgeons at Guy's and St Thomas's Hospital in London. And we have a large cystinuria practice there and have also jointly worked with the ERN for renal disease ERN. So this is a slide of our conflict of interest. So as I've just mentioned, this is a collaborative piece of work between eUROGEN and ERN. The advantage of this is that patients across Europe have access to experts from both areas, in the form of an MDT. We've also published consensus guidelines on the subject of cystinuria, and we've had joint meetings and are in the process of agreeing a joint registry for this disease. So if we look at some history of cystinuria, this is an excerpt from the first reported cystine stone, which was actually misnamed as cystic oxide. It was published over 200 years ago by William Wollaston. And interestingly, these two observations that he made are true today. He realized even then, having seen the first stone, that this was probably a rare form of stone disease. And he also commented on the homogeneous appearance, the crystals and the yellowish appearance of the stone. So these pictures on the left show a line drawing from an essay a few years after this stone was described. And on the right, the blue stone is actually the original stone, which is housed in the Gordon Museum at Guy's Hospital. And nobody's really quite sure why it has turned blue over the years. So how rare is cystinuria? Well, this is difficult to answer at the moment. It has a worldwide prevalence of 1 in 7,000. But as you can see, the actual incidence varies hugely depending on which country you look at. And I've just shown the numbers here for Japan and the UK. The incidence is equal for male and females, although there's some evidence that the disease severity may be worse in males. We don't know what the true incidence is across Europe, and this is where registries will help us with this. So given that this is a rare disease, it's not uncommon for patients to experience quite a significant delay in their diagnosis. And in our patient cohort, that's been as many as 1 in 4 patients who've experienced a delay, with the average being 7.5 years. Patients generally present in the 2nd decade, as you can see in this graph. And for this reason, it's important to suspect and investigate for cystinuria if the patient is young at the first presentation of their stone, frequent recurrence and frequent spontaneous stone passage, and a whole host of other markers which are shown below. So what is cystinuria, or how is it caused? Well, it's due to a failure of reabsorption of 4 amino acids, cysteine, ornithine, arginine, and lysine. And these are all transported through one mechanism, which has 2 subunits as shown in this diagram below. This mechanism is found both in the intestine and the proximal tubule of the kidney. In the proximal tubule of the kidney, a defect in this transport mechanism means that there's an accumulation of all 4 amino acids in the urine. But the only one that's clinically relevant is cysteine, because it's not soluble in the increased amount that is then found in the urine. The transport mechanism has 2 subunits, one heavy unit and one light unit, and these are coded for 2 different genes that we'll come on to discuss in a moment. So the biochemical structure of cysteine is actually a dimer of 2 cysteine molecules, and often you'll see this misspelt as cysteine. There's a disulfide bond that links them to form the cysteine molecule. It's this disulfide bond that is cleaved when you use a laser to break up the stone, and this releases a sulfur or offensive smell, which is very diagnostic in theatres of a cysteine stone. So the classification of cystinuria used to be biochemical and was based on the biochemical parameters of the parent's urine rather than the patient. And this is largely historical now, and we don't really use this to classify our patients anymore. Much more recently and more accurately, we use genetic classification with these 2 genes that I've already mentioned. So on chromosome 2 is SLC3A1, which codes for the heavy subunit RBAT, and SLC7A9 is on chromosome 19. The genetic classification is based on mutations of SLC3A1 in type A and mutations of SLC7A9 in type B. If there's a mutation in both genes, then the patient is classified as type AB. The cystinuria inheritance pattern is also interesting. So SLC3A1 and SLC7A9 can both be inherited in an autosomal recessive pattern, which means that you need both copies of the gene to be mutated in order to manifest the disease. If only one copy is mutated, then you're a carrier. However, SLC7A9 is interesting because in some patients who only have one mutated gene, they still form stones. And that's why this one is called autosomal dominant with incomplete penetrance. So how much progress have we made with genetics? Well, we do understand a lot about the genetics of cystinuria, and we realise that it's quite a diverse disease and varies across geographies. We're also fortunate that we now have mouse models based on the genetics and can test new therapies using these. But what we really want to know is what's the impact of these individual mutations to offer targeted therapy? How might we predict prognosis and response to medication based on genotype? So I'm just going to hand over to my colleague now, Matthew Bultitude, to talk about the diagnosis of this disease and also the clinical examination and clinical follow-up.
Good evening, thank you. So the diagnosis of cystinuria is based on at least one of these three things. So stone analysis showing a cystine stone, observation of cystine crystals in the urine, or finding of abnormally elevated levels of cysteine and the other amino acids in the urine. Genetic testing is not needed for diagnosis, and that's very clear in the latest EAU guidelines. It can occasionally be useful both for diagnosis and genetic counselling, but the problem is that no major genotype-phenotype correlation has ever been identified that would help stratify our patients, either in terms of treatment or outcomes. So what do we do in the clinic? Well, obviously we assess them to see if they've had any pain episodes or definite stone passage. In terms of tests, we check their blood pressure and renal function and look on urinary dipstick for blood and proteinuria. We check the urine pH in clinic, but we often also ask our patients to complete a pH diary in advance to check the pH on different times of the day to see if they're adequately alkalizing the urine. We check their urine cysteine levels and also look for crystalluria. In terms of imaging, we use ultrasound as first line and only offer CT if needed to try and limit ionizing radiation. In terms of CT scanning, Hounsfield units are often used in stone disease to try and judge stone hardness, and cystine stones are often thought to be typically quite hard. So we looked at this in our cohort of patients and actually found that Hounsfield units are not helpful in judging the hardness of stones, as almost all cystine stones have relatively low Hounsfield units, below 800, as you can see from this graph. So if you're seeing a patient and the Hounsfield units are greater than 800, you should suspect it's not a cystine stone. And if it's a patient with cystinuria, suspect whether there's been another type of stone, in particular calcium phosphate, formed. This is an example just to demonstrate this. This is the same patient who underwent a PCNL. When we look at the bottom half of the stone here, we can see that the Hounsfield units are in the region of 700, and that stone is shown here and has got a typical appearance of cysteine, and that was what was found on stone analysis. But when we got further into the stone, to the top half of the stone, as it approached the renal pelvis here, the Hounsfield units are nearly 1300, and you can see that the stone looks like a very different type. And so we sent that off for separate analysis. In fact, that was calcium phosphate. This is a predominant cystine stone, which then formed a cystine cap on the top of it, and that could actually be predicted from the CT scan. So what cysteine measurements can we look for in the urine? So we put in bold here the common three. So we can do a spot urinary cysteine level in the clinic, or we can do a 24-hour urinary cysteine level with the problem that patients have to collect that and bring that in, and they often travel long distances to clinic. Looking for crystalluria is useful, and there is a positive association with the finding of crystalluria and stone formation. The other tests are probably less common, but we can use cysteine supersaturation, or another test of supersaturation called cysteine capacity, which is a proprietary test for an American company. We can also look at drug cysteine complex levels to look at binding of the drug and therefore potentially reducing the level of cysteine. The recent guidelines that were published in Kidney International earlier on this year make some useful statements in this area. They say that crystal urea is as a useful tool in the management of patients, but it does require standardized methodology that's not available in all centers. And the monitoring of the urinary cysteine is of limited value in the management of patients with cystinuria. That is potentially because the cysteine actually comes into a solid state to form the stone, so the level of cysteine is reduced in urine and is therefore artificially low when we measure it. So this just shows the setup for our clinic at Guy's Hospital. We try and run this as a one-stop type model where patients have a joint consultation with urologist and nephrologist when they attend. As I've said, we check the urine for pH, amino acids, and cytology, and all our patients are offered genetic testing. We offer all patients an ultrasound in clinic by a dedicated uroradiologist, but also have X-ray or more commonly CT scanning if needed. All patients are also reviewed by our dietitian within the clinic. And for patients who need surgery, we try to offer them a date within 2 weeks to try to minimize the wait time that they have with their stone. And all patients are given our specialist nurse contact so they can easily get in contact with our clinic. The frequency of follow-up is going to depend on the disease activity and the frequency of stone formation. It's also important to remember that we are going to be checking blood pressure and proteinuria in patients who need it. And it's also vital, as we'll talk about in a minute, for medication monitoring. And that's clearly stated in the guidelines, where it suggests ultrasound as first line for imaging, with CT as second line, and that the frequency of follow-up will vary between 3 months to annually, depending on the activity of stone formation, and that's exactly what we do. In terms of medical management, of course, we're looking to reduce the urinary cysteine concentration, but this is usually really assessed by by stone or clinical episodes. In terms of treatment, diet and fluid is vital for all patients, and we ask patients to complete their pH diary to see who needs alkalization. For patients who still form stones despite optimizing these things, they are then offered chelating agents with either tiopronin or D-penicillamine, depending on availability. And I know that now both these drugs are not necessarily available in all countries. What's clearly stated in the guidelines recently is the Captopril is no longer recommended as a third-line treatment for cystinuria, as it's ineffective. In terms of dietary considerations, we ask all patients to limit salt intake, like all stone formers really, but it's been clearly demonstrated, as you can see from this graph, that as sodium excretion rises, so does cysteine excretion. So there's an obvious potential benefit to limiting salt. Animal protein is rich in methionine, which is the precursor to cysteine. It's been shown that patients on high protein diets have increased cysteine excretion. So following a low methionine or low animal protein diet is important. It is, however, imperative to ensure that there is adequate alternative protein in the diet, and that is the role of our dietitian. And it's also important to say that we don't advise limitation in children due to growth. I said that fluids and alkalization were going to be in the cornerstone of management, and it's vital that patients achieve at least a 3 litre per day urine output, and often more than that. To achieve that, you're going to have at least 3 to 4 litres per day. But only rarely really do patients have to set an alarm to drink at night and avoid. Alconization is usually with potassium citrate, and we aim for a target pH of between 7.5 and 8. And you can see why from this graph on the right-hand side, where the solubility of cysteine rises significantly in this pH range. Going any further does threaten the formation of calcium phosphate. For patients who can't tolerate potassium citrate, or if it's contraindicated, then we do use sodium bicarbonate, but obviously that does give a sodium load. And this is stated in the guidelines, which advises that patients self-monitor, trying to achieve a pH of between 7.5 and 8, using strips, dipsticks, or electronic devices. And I put these little pictures in here just to show one of our more obsessive patients who bought an electronic meter and then for a few weeks measured his urine pH every 2 or 3 hours during the day and correlated this with everything that he ate or drank, so we could identify what happened and what caused his pH to dip. He found that things like beer and red meat in particular caused it to drop, and then he tried to mitigate that by drinking more at the times that he ate or consumed those things. For the chelating agents, they cleave cysteine and then complex with cysteine, which has a 50 times higher solubility than cysteine. The efficacy and side effects are reportedly similar for both tiopronin and penicillamine, and both have a significant side effect profile, as I've shown on this slide here. For that reason, it is essential that patients undertake regular monitoring as advised by the manufacturers, which initially is every 2 weeks for the first 3 months, with assessment of the urine for protein and the serum for blood count, renal and liver function. I've put the doses on the slide here, but the typical starting dose is around about 1,000 milligrams a day for both drugs in divided doses. The drugs do work. That's good news, isn't it? And we've shown that in our patients that it was up to nearly 40% reduction in stone episodes and need for intervention for patients who were able to maintain on medication. It does come with a significant side effect profile, as shown by this French group here, who found that up to 30% had at least one side effect. And you can see from the graph, that's broadly spread over urinary proteinuria, GI, hematological, and skin side effects. There are funding issues, and this varies by country, and there often are problems with supply. It's vital to monitor renal function, and we found in our patients that 3/4 of our patients have abnormal renal function, as measured by an eGFR of less than 90, and half of our patients have hypertension. And these very similar findings were found by the French group, who found nearly 80% had a reduced eGFR and 30% were hypertensive. So now just moving on to the surgery that we do, and these two pictures just show some of the problems that the patients face. So this is one of our patients, and as you can see from the picture, she's had bilateral open surgery in the past, and you can try and count the scars, but probably maybe 15 PCNLs over the years for recurrent stone formation and many other ureteroscopies. And on the right is a different patient who had a stent inserted for an obstructing stone 10 days prior to this procedure. And you can see that there is early incrustation on the stent even at 10 days. And that is why it is vital to try and minimize the indwelling stent time in all cystinuria patients. So the principles of our surgical approach: we do offer shockwave lithotripsy. Some stones are soft, and so patients who've had successful lithotripsy before, who've never tried it and have stones less than 10 millimeters, it may well be worth trying lithotripsy if this is available. Patients should definitely be offered early treatment if the stone is unlikely to pass, to try and prevent long-term renal damage. And of course, we should aim to render patients stone-free as possible, and that goes for all stones, but even more important in metabolic stones. We believe there's an extended indication for ureteroscopy, and so we offer ureteroscopy for larger stones than you might otherwise do, partly because they have wider ureters, so it's easier access, but also to try and minimize the insult of repeated percutaneous access. Patients may need less stenting due to these dilated ureters. I just showed you the risks of incrustation. Stents can encrust very quickly. And with recent advances such as combined ureteroscopy and PCNL procedures, so-called ECIRS, this is proven useful, as we'll show you in a moment, to try and render patients totally stone-free. This algorithm can be seen in the guidelines paper, but it just highlights really the extended indication for ureteroscopy, which is potentially first line for stones up to 20 millimeters in most locations in the kidney, and really optional for lower pole stones up to 20 millimeters as well. And that decision will be based on anatomy, previous findings, and also patient wishes and local expertise. We're just going to show you just some little examples. This is a patient who presented with a large pelvic stone, 16 millimeters. After discussion with him, and he's had previous ureteroscopy and PCNL, he opted for ureteroscopy. And I'll just show you a little bit of the video. Actually, the stone doesn't look so big because it's quite a dilated renal pelvis here, but it's a 16 millimeter stone and may often be offered PCNL. We start on a relatively low setting with the holmium laser here, just to see how it's going to fragment, and it does appear to be fragmenting, to be dusting quite nicely. And so I'll just skip on a little bit. And you can see here, well, what we're trying to do here is just paint on the surface of the stone. So rather than just try to drill into the center of it and create multiple fragments that then get dispersed around the kidney, you actually want to just try and keep just one stone and just try and get it smaller and smaller. And then this is a bit later on in the procedure. This is some fragments now that we've pushed back into a calyx, just getting these as small as possible. And then finally, and this procedure was about an hour. This is now just coming back into the renal pelvis where the original stone was and showing that predominantly that's been fragmented into dust and tiny fragments. And he was stone free on ultrasound at 3 months. I'm going to hand back to Kate.
Great, so now we're looking at a large pelvic stone. Unlike the previous case you saw where we treated this with ureteroscopy, we decided to treat this with a PCNL. This is a 3 centimetre stone, so bigger than the one that you were just seeing in the video. The difference is that we now would tend to use a mini PCNL, so a smaller diameter nephroscope than we would have used historically. That means you do have to use a laser because you can't pass the suction device down this diameter scope. But as you can see, when you look across these pictures, this was a large stone in the renal pelvis. Lots of fragments were removed, as you see in the picture on the right, and the patient was stone free. The advantage of the mini PCNL is that you have less renal damage, less bleeding. The disadvantage, if it's a patient with infection, is that there's an increased rate of sepsis and infection afterwards. But that doesn't tend to be as much of a problem in a cystinuric population. So now we're going to come on to look at a complex staghorn stone. You can see the CT, which shows a small stone on the right, proximal ureter, and then a staghorn calculus in the left. On the 3D reconstruction, you can appreciate the complexity of that staghorn calculus. We therefore decided to do a combination of the 2 procedures you've just seen. So a flexible ureteroscope up into the kidney, which you can see in the first picture on the left. You can see how much of the collecting system is occupied by this staghorn calculus. And then in the middle picture, you can see the flexible scope and the nephroscope in the kidney at the same time. The patient is lying supine but rotated, which is why the spine looks as it does on this X-ray. And then in this video, you see that we've cleared the majority of the stone from the renal pelvis through the nephroscope. But because the nephroscope is rigid, we're now using the flexible ureteroscope to access the calyces that we couldn't get into. And we're taking advantage of the hardness of the cystine stone to break off fragments and release them from that calyx. And here you can see us trying to maneuver a fragment out of the calyx into the renal pelvis using the flexible scope. This same fragment has been removed in a similar way to this video showing you now, where we've got the fragment in a basket and then we're passing it down the nephroscope, so-called pass the parcel maneuver. And this means that we can remove quite large fragments from calyces without having to laser them completely. So what's new in cystinuria? For many years, maybe 3 decades, there have been no new medications. You've heard from my colleague already about the medications that we use as standard. But actually over the last few years, with the interest in rare diseases has come funding and research into new therapies. Some are versions of treatments we have already, such as alconization. There's a new preparation of potassium citrate and sodium bicarbonate that's in trial at the moment. There's a thiol, which has been around for a while, called busilamine, which is being trialled for use in cystinuria. Tolvaptan, which produces a large diuresis and is currently used for adult polycystic kidney disease, is also being trialled for use in cystinuria because of the obvious potential benefit of diluting the cystine load. There are 2 herbal medications available. One is called Cystone, which in current trials has not shown any difference in stone formation. And the other one is alpha lipoic acid, which is undergoing trials at the moment in patients. The cysteine analogue L-CDME is a real success story of the research into cystinuria over the last few years. This compound has really come about from some exciting work looking at atomic microscopy and really understanding how these cysteine crystals form, and from that has become able to make a cysteine analogue that basically disrupts crystal formation. This compound has then been tested in knockout mice using the genetic information that we have and found to successfully reduce the stone burden in mice. At the moment, it's still undergoing trials in mice because of concerns around the safety aspect and the safety profile. And so it's not yet ready for a phase 1 trial in humans. So the other thing that we have, which is new, is clinical recommendations and guidelines for cystinuria, which are really important for rare diseases. Often the patients may know more about the disease than their doctors, and I think both of these documents provide a really useful resource for clinicians seeing these patients with a rare form of stone disease. The top one is the one that we've mentioned as a joint collaboration with ERN, and the one at the bottom is from American colleagues. So I'm just going to hand over to Matt to talk about the patient.
So for a chronic condition and a rare condition like cystinuria, patient support is very important. Because it's a rare disease, loneliness is a problem, and there is often no peer-to-peer support. And often cystinuria patients have never met another patient with the condition. Doctors also don't know as much about as the patient about the disease, and often may not listen. It's quite common for cystinuria patients to attend the emergency department, and the physicians there have never seen or heard of cystinuria. There are also concerns about pregnancy, and we've looked at that in our patients, and there is significant anxiety amongst patients about getting pregnant. Thiol medication has to be stopped in advance, which then leads to an increased risk of stone formation, and then patients need careful counselling and monitoring throughout the pregnancy. I think there was a lack of patient information and websites, but I think that has been addressed, and I'll show you a little bit of that in a moment. And it's been clearly shown both in American series and in our patients in the UK that there is worse health-related quality of life in cystinurics compared to other non-cystinuria type stones. So the aims really is to improve understanding and compliance with diet, medications, and monitoring. What we've really tried to do is empower patients to try and help themselves in this area. So over 10 years ago now, we set up a website called Cystinuria UK at the request of our patients because they found the information available to them fairly inconsistent. There is also an American website from the International Cystinuria Foundation which can be accessed. We've had several patient days in the UK where patients have come from all over the United Kingdom. And in fact, we've also had patients travel from across Europe and Israel to that day and meet other cystinuric patients. We've created 2 cookbooks for our cystinuria patients, which highlight recipes with low animal protein but healthy, balanced diets. And those can both be downloaded from our website. And again, at the request of our patients, we recently set up a forum on a platform called Health Unlocked, and you can see a screenshot of that here. This is essentially Facebook for health, and so patients have to have a login, but then can ask questions and answer that themselves with some mild moderation for ourselves. And the International Cystinuria Foundation also have a large Facebook group for cystinuric patients. And finally, I thought it would be topical and relevant just to mention COVID and cystinuria. Clearly, COVID has had an impact on all patients and all of us, but it's particularly had an impact, I think, on patients with rare diseases. And we sent a survey around to our patients in the middle of last year, so about 3 to 4 months into the pandemic. At that time, nearly 3/4 of them were shielding, although only 12% of them had officially been told to do so, and that has problems because they don't get some of the benefits of being official shielders. A lot of people weren't able to work as usual, and that was certainly true in this patient. In our patients, where only 16% were going into work as usual, About a third were able to work from home. And worryingly, half of patients had difficulty obtaining their thiol medications. And in this time period, 40% of them had experienced an episode of colic or passed a stone during those first few months of the pandemic. And 50% of those patients were worried about whether they could attend the emergency department, whether it was safe to do so. And for patients who had had clinic appointments around that time, 60% of those had been cancelled by the hospitals, which is maybe not a surprise, but does put these patients at a risk. There was a slight flip side that when we did survey them, they generally reported that they'd found it easier to stay hydrated because they were at home more and had easier access to water.
So in summary, that's an overview of the treatment and management of cystinuria, and our take-home messages are on this slide. Clearly, this is a challenging condition to treat. We do recommend diet and fluid advice for all patients. Alconization should also be considered in the majority, but tailored to the patient with pH testing. And it's important to do this both when the patient starts and also after they've been established for a while. Chelating agents are really useful despite the side effects, but it's important to remember monitoring. Patients need easy access into services because of the rare disease, where their local services may not understand it. They need regular follow-up with ultrasound to avoid the radiation burden that may happen with X-rays and CTs. Patient engagement is really important in empowering them to manage their own lifelong chronic disease. And lastly, we should personalise the surgical approach, make them stone-free where possible, and minimise the stent dwell time. Thank you very much.
Okay, that's the end of the presentation. So Kay and Matt, I don't know if you're able to put your videos on, and I'll stop sharing the video. So we've not had any questions come back through so far, but so now's everyone's opportunity. If you have any questions on that, please send them through using the questions tab. I will then pass them on. I don't know if Kay and Matt, you want to say anything after that to add to it or not?
Yeah, thanks, Darren, and thanks for your help with recording the video. I thought maybe while people are thinking about questions, something that comes up quite commonly is around starting a family for these patients, because they've been given advice before. Sadly, some of our older patients never had a family because they were advised against it. I just wondered, Matt, you talked about a survey of our patients who had children. What kind of themes came out of that?
Yeah, thanks, Kay. So yes, we looked at this in a group of our patients. We actually only surveyed the patients who'd had children, so it may be a little bit biased. We chose not to ask our female patients who hadn't had children. Around about a third of them had felt that cystinuria was a barrier to having pregnancy at all, which of course is a concern. And about a third were taking medications that they remember taking medications that they had to stop during pregnancy, and so therefore putting them at greater risk. And then this is all based on recall, but about a third had passed stones or remembered passing stones during the pregnancy, and about half felt they had formed stones during pregnancy that subsequently needed treatment. So clearly from that data, that suggests that quite a lot of patients have problems during pregnancy with stones or subsequently need surgery. But then in terms of reassuring our patients, we've also had a number of patients who've had children while we've been looking after them through the clinic, and we've been able to get them through that without difficulty. So, I mean, I think that's part of what we try to do in the clinic, is try to address that with them, try to reassure them that it's certainly possible and feasible. We'd like to try and get them as stone-free as possible to start with. And so if they're planning a family, then maybe we want to remove any small stones just to give them the best chance of not having a problem throughout their pregnancy, and keep them on regular surveillance with ultrasound. It's also important just to link in with their obstetrician, who also, like many people, won't know much about cystinuria, just that they understand that, and we'll keep a closer eye on them. And of course, some of our patients are hypertensive as well, so that's important for the obstetrician to be aware of. So yeah, so I think in summary, I would say that our patients definitely can have children. They've proven it. We just need to keep a close eye on them. And then the other question that comes up is a concern about, and this was a very common theme in our survey, was that 90% of them were concerned about whether their children would have cystinuria, and that may be one of the barriers that they're concerned about as well, about having a family. And so we're usually able to reassure them that it's actually very unlikely that their children will have clinical cystinuria, because, as you said in the presentation, it is typically autosomal recessive, and so you have to have 2 copies of the faulty gene. So therefore, they'd be very unlucky to give for their children to have 2 copies of that faulty gene. So although they will be carriers, they won't actually develop clinical cystinuria.
Great, thank you. Darren, there was a question that appeared in the screen, and then
I just resent it to you, so I don't know if you can see it now. I can read it out. It says, how about alconization in pregnant women with cystinuria?
Okay. Matt, do you want to take that or me?
I don't mind. So alkalization, I mean, alkalization in the urine is fine, so we continue with alkalization through pregnancy, but you do have to stop thiol medication. In some of our women who have had to stop thiol medication, we then really recheck their urine to make sure that they're absolutely alkalized as possible, to give them the best reassurance throughout their pregnancy that they're doing everything they can.
Great, thank you. So there's another question about the cystinuria inheritance, about SLC7A9. So asking whether the affected children form stones or just carry the gene. So I think, as I was trying to explain, although the SLC7A9 is a bit more complicated, so SLC3A1 is a straightforward autosomal recessive pattern, and the majority of patients with SLC7A9 also follow that same autosomal recessive pattern, i.e. they need 2 mutated genes. However, we've got a reasonable number of patients, maybe 6 or 7 patients, who actually do have stones and only have 1 mutation in the SLC7A9 gene. And those are the ones we were referring to as having autosomal dominant with incomplete penetrance. So SLC7A9 can behave in both ways, but most typically it's autosomal recessive. So it makes, in answer to what Matthew was just saying about pregnancy, it makes it a little bit more complicated in those patients who are going to have children and have got a mutation in SLC7A9, to totally reassure them that their children won't be affected, but in the majority of times they aren't. I hope that answers that question. So Matthew, a question about pH profile. How many pH assessments should there be a day?
So we usually ask our patients to keep a diary at home, and probably only just do it once a day, but just at different times of the day as they test it throughout the week. So you don't have to test each urine as that patient did in the thing that I showed, where he'd obsessively checked every single urine he did. But probably just 1 a day for a week or 2, just to get a little pattern of what happens. But just make sure it's done at different times, so you can then see where they're alkaline, if they're having regular time periods where they're acidic and would therefore benefit from alkalization prior to that.
Great, thank you. I don't know if there are any other questions.
No other questions at the moment, okay, but if there's anything else you wanted to talk about while we wait, or?
I just wondered about the Health Unlocked website, actually. It might just, or support forum, it might just be helpful to talk about who can access that, Matthew, because it's not just for UK patients, which people might think, given that we're from the UK. Yeah, no, sure. So the website, when we set it up, the website itself, Cystinuria UK, was obviously, as per the title, aimed mainly for UK patients, but it's been accessed around the world quite widely. So actually only about 1/3 of users are from the UK, which means 2/3 are from elsewhere in the world. So that's quite encouraging and showing that patients are being able to access and get that information. For the Health Unlocked forum, we set that up intentionally to try and be a worldwide resource. So it's called Cystinuria Support on the Health Unlocked forum. And Health Unlocked, like I said, is a bit like Facebook. So you go to it, you register, and then you can find
different groups that you want to follow and join. So Cystinuria support is one of them. It's difficult to know from some of our data because you don't have to say where you're from, but we certainly know that whilst, of course, quite a lot of our patients are onset from the UK, but actually we definitely have patients from across Europe and further afield. So it's definitely designed for all Cystinuria patients across the world.
Great, thank you. I don't know if anyone else is wanting to post anything.
Yeah, so I'll say we give like another minute, and so if anyone doesn't want to ask anything else, then please do so now. Oh, here we go. Just send them on to UK.
So this one says, is it necessary to avoid dairy products or only meat? So that's a good question, and something our patients get a little bit confused about at times, because when you talk about animal protein, patients often say, well, I don't really eat red meat, I just eat chicken and fish. And of course, that counts as animal protein, as does dairy products. So I think the answer is everything in moderation. We're not suggesting that people need to go on a vegan diet if they have cystinuria. It's more just tweaking their intake to try and reduce the methionine load. By far the most important dietary thing they can do is increasing their fluid intake, and we spend a lot of time helping them understand that and understand some foods that have quite high fluid content, so that not all of it's about drinking lots. The uptake of the dietitian is very popular in our clinic, and patients do that in a variety of ways. Some have become vegetarian by choice and have found that's really helped with their stone formation. Clearly, it can have other health benefits as well. But the dietitian does also monitor things like grip strength and other sort of parameters to make sure that when people do change their diet, they're not doing themselves any harm, and it is done in a balanced way. And in particular, takes account of any other medical diseases they may have, or conditions that mean that their diet has to be taken into consideration. So avoiding some dairy, but not becoming dairy free, and likewise with meat, looking at the portion size, for example, rather than cutting out meat completely for some patients who just can't manage that. I hope that's helpful.
Okay, yeah, we've had nothing else come through, so I think probably leave it there. It's coming up to not far off the hour. So thank you both, to Kay and Matt, for doing the presentation today. Much appreciated. Thank you to everyone who joined. Just to let you know, we'll be putting a recording of the video on our YouTube site and also on our GoToWebinar channel tomorrow. So we'll send out a link to those so you have them directly. Please also check out our website for forthcoming webinars. We put on sessions for the rest of the year. We'll be changing things slightly for next year. We'll be upping the numbers we're doing and also changing to Wednesdays rather than Tuesdays. But we'll put something on the website about that and tell you about that in future webinars. Actually, just another question's come through as well while we're waiting, so I'll send it on to you. It says there's a follow-up to it as well. Okay. So,
oh, right. Okay.
Yeah.
Sorry, the way it's displayed, part of the question's getting cut off. There we are. Hold on.
Okay, you got it. Yeah, cool.
Yeah, I've got it now. So for somebody with a high pain threshold, are they doing kidney damage by not going straight to A&E, i.e. if experiencing colic, vomiting or pain? I think I'll sort of start with that and then I'll pass it on to Matt. That's a difficult question, isn't it? And yes, certainly some of our more experienced, if that's the right word, stone formers do sit at home and sit out episodes of colic because they're well used to it and they don't feel that going to A&E adds much for them personally. Clearly, they have to be sensible about that. We have had some of our patients with a solitary kidney who quite worryingly say they're going to stay at home, and they are at particular risk. And quite a few of cystinuric patients have either got a solitary kidney from having one removed in childhood or one kidney that's smaller or atrophic. But I think with those caveats aside, and assuming that they don't have an infection, then often patients do manage their own pain at home, and they have particular remedies which couldn't be recommended by us as medical professionals, such as drinking beer, in order to pass their stones. So I think with those caveats that I've just mentioned, then often people can stay at home and successfully pass quite a large stone because of the increased diameter of their ureters, which Matthew mentioned. Did you want to add anything?
Yeah, no, I think it's a really good question, and a question that does come up all the time, doesn't it? I mean, as you say, I think it's very important to be sure that they've got a normal contralateral kidney. That is important, and also that there's no signs of infection or sepsis. So any fever, then they must go straight to the emergency department, and that's very clear. I think beyond that, and in other non-cystine stone forms as well, if you know what the diagnosis is, then I think then it is reasonable to give it some time to see if you can pass. There are some very old animal studies that looked at complete obstruction and showed that you didn't do any damage to the kidney with complete obstruction for 2 weeks, but you did beyond 6 weeks. And that's sort of why stone patients are often followed up for a couple of weeks to see if you go to A&E, they're diagnosed with stone, they send you home, don't they? And then get followed up in 2 weeks, and if you don't pass, you operate within 6 weeks, and that's where those timeframes come from. So do patients need to be told on a scan that they've got a stone if they know they've got a stone? I'd say probably not. But if they don't pass it, then they need to be seeing somebody within 2 weeks, I would have thought. There is a downside from going to the emergency department that you'll almost certainly get stuck in a CT scanner, of course. And it's very hard to stop that happening because that's just a machine that happens, and it churns people through. And we certainly tell our patients to try and avoid that where possible, and have ultrasound if it's feasible sometimes, just to try and avoid that, because this could happen to them several times a year for their entire life, and you don't want to have CT scans for every single episode, do you?
Yeah, I completely agree with that. And we give our patients a little card actually requesting that they can show when they go into A&E, requesting that they don't get a CT unless necessary, and explaining why, and giving our contact details, so that if anyone's on here who does have these type of patients, can be really useful for them to have a letter or a card just explaining the disease, and giving a little bit of information that the patient can show, because they're often not in quite the right physical state to be able to have a conversation with somebody when they first go in. That's great, really good questions, thank you.
Okay, yeah, I think we haven't had anything else come through. So again, thank you, Kay, and thank you, Matt, for doing this today. It's much appreciated. And yeah, thank you to everybody else, and we'll call it a day there. Thank you all.
Great, thank you.
Thank you.
Good evening.